cardio is not just a tool for calories out. You can do cardio from doing supersets and giant sets or whatever, but you have to do some form of cardiovascular training to be able to actually support having high testosterone. I tend to kind of sit more on the side of conservatism with most things. I think it's better to be safe than sorry, particularly when we're making interventions in people's health. But
I don't know if everyone knows, but hematocrit's a calculation.
Yep.
I think it's the mean cell volume times the red cell count.
Yep.
I think divided by 100
Yep.
gives you the hematocrit number. So
Yeah.
I had an incident, and this can happen also. Guys have to be aware of this if the lab holds on to your bloods too long.
Too long, yeah.
And the swells, or if you think you're going to be cheeky and really change that formulation and just drink loads of water,
Yeah.
an hour or two before the test,
Yeah.
you can cause the red cells to swell, and you have a larger mean cell volume, and it goes in the calculation. You think you've got this massive hematocrit, so both can cause that. But I know there's been that's a concern of a lot of people, is what's going to happen to their red blood cell hematocrit hemoglobin on treatment, and how dangerous is that for their heart health. And I think there's different sides in the TRT world who some will say, no, we have to phlebotomize, we have to get everything into order, or lower the dose, or a combination of both, maybe baby aspirin. And others will say, no. I think like Dr. Rouzier did a presentation saying that only the data that's like that is for kidney patients who have kidney failure, but everyone else, it doesn't seem to be an issue. What have you seen?
I think this is a great topic because there are people who I love and respect who disagree. And this is what I like, because there's nuance, and I think there's multiple ways to skin a cat, and I think that there is different ways of looking at this, and I think that it's going to come down to a variety of factors for the individual. But I tend to kind of sit more on the side of conservatism with most things. I think it's better to be safe than sorry, particularly when we're making interventions in people's health. But I look at things quite holistically as well. So you've got one side. Firstly, when I look at it, is that you could have polycythemia from being obese, sleep apnea, alcoholic, poor cardiovascular fitness, and you can have someone who's very healthy and lean, who's had their red blood cells increase from androgen therapy, and they will both reach the same hematocrit number. That is two completely different scenarios in terms of what we're looking at, which at the end of the day, I would assume is going to be all-cause mortality. You don't want to die. So the difficulty when we're looking at this is, one is increasing in the context of someone being very unhealthy. The other one is increasing in the context of increasing red blood cells to be able to increase oxygen capability of the body, to be able to basically use more oxygen, which is part of the therapy of what we're trying to achieve with testosterone. I sit in the middle because I go, well, if you do this on top of this, then now the blood's going to be like fucking goo. That's how I look at it. So I think that we're in a scenario going, and this is kind of going back to what I spoke about before and at the Silverback Summit, is that if you take the healthy levels of a 21-year-old and put them into an unhealthy 50-year-old, if you put a sports car engine into a Suzuki Swift, it's going to blow up, it's going to fall apart. You might feel great ripping out of the car park, you might feel like King Kong, but if your hematocrit goes up to 60, 65, your heart's going to be working really
hard.
So I think it's a tricky situation when we're going, okay, well, yeah, idealistically, they're not going to have sleep apnea. They're going to be lean. They're going to be doing cardio. But what about when they're not? What do we actually do? And our mutual friend, Dr. Rudy, he made a video the other day on this saying that he was, a proponent of phlebotomizing here. I think that if you've got someone who's coming into you, and again, I'm not a doctor, but I imagine if I was a doctor, if I'm in a situation where someone's a metabolic emergency, I have a duty of care, and I genuinely don't want to see harm come to the individual, might be going, okay, maybe a phlebotomy is a good route here, especially because getting to the point that you don't need a phlebotomy might take some time. And I think that that's where, and this is what Dr. Rudy spoke about before, is going, we're not just looking at the number on paper, that once you get up to whatever number I decide, then bloodlet. But we're going, okay, well, what are your symptoms? So if someone's got a hematocrit hemoglobin of 55, 56, blood pressure's low, they're feeling great, no issues, versus if someone's got a hematocrit of 53 and they look like a turnip, then that's going to be a different scenario. But I think the nuance here is that there is no circumstance in which an unfit, sleep apneic, obese guy who never does cardio is going to have a total testosterone of 40. So I think now we're going, okay, we're creating an unnatural situation here. has this been studied? Has this specific thing been studied? No, we're extrapolating from different circumstances that don't apply. So I think there can be, if someone is in a situation where they need a phlebotomy, ideally we want to get them to the point they don't need that. Healthy men do not have to bleed regularly. It's not part of that.
Though there was an Australian study about the forever chemicals, and frequent phlebotomies can help remove the forever chemicals from the blood. So it might not all be bad. There may be a therapeutic reason for doing it. I think that the negative of the therapeutic phlebotomies are, you get this rebound effect. You can take too much out in one go, or in a too close a time. So preventing it is better. So if you did, we've always said, it just as a nice thing to do is donate blood, because you've got plenty of red blood cells, especially if you're on treatment, and just do it at the normal time intervals that the blood donation services like to take it. I think even win a dinner at the end of the year if you go through all the different times that you're supposed to donate. Then I think that's okay. There's nothing wrong with that, and people can use it for the blood supply. Unfortunately, sometimes when you're on TRT, the blood supply, people don't want to take it. Because you'll get this misdiagnosis of polycythemia vera, which is completely different. And I still agree with Ruzi about erythrocytosis, but sometimes they get used synonymously. And I think the other point is there's certain guidelines that have been set up. I think the European guidance is over 54%. And have kind of some sort of intervention, either stopping treatment for a short period of time, lowering the dose, increasing the frequency between injections is another area. I think the third thing we've noticed, and there's some studies that show that the free testosterone level, how high it is the greatest predictor of this increase in red blood cells. So if you can kind of manage that, you may be able to prevent it. So sometimes lengthening, I know this is counterintuitive to the microdosing philosophy, is sometimes increasing the length of time between injections gives it enough time to clear. So now you've got a lower trough level, and that's sometimes more suitable than stopping therapy altogether for some patients. And then I've also seen the guidance talk about sometimes the baby aspirin in those cases to probably thin the blood. One thing that I'd used in the past is pentoxifylline, which is almost a generic PD inhibitor. I think it's PD5, PD4. It helps the blood flow more easily. It has some anti-inflammatory effects. It lowers TNF alpha, TGF beta 1. Quite helpful, but it's not really a new drug and not sexy. And a lot of people don't know about it, even though I think the BMJ had written an article about its usefulness in heart disease. So there's lots of different things people can do. I guess, like I said, there's more the way to skin a cat. But sometimes it's one of those things people get very, very worried, especially when it comes to blood viscosity, their health. And I think the best approach is, like I said, being a bit more conservative with what you're doing.
And I think that the important caveat for it is that people don't band-aid the underlying metabolic issue that's causing the problem in the first place. And if we're in a situation being like, okay, go get phlebotomized at X interval, that's a band-aid, not a solution. And what we wouldn't want to do is be doing that to prevent someone from getting a sleep study or increasing their cardiovascular fitness and all these kind of things, which I think is, and that's, again, coming back to the importance of the health coaching and working with them from an educational model.
So what is it about cardio? And I was going to say, that's a very good point, that usually that was a red flag for us when we get a patient that comes back with an elevated hematocrit hemoglobin. What you also need to investigate whether it is a sleep apnea that's causing it, or if they're a smoker. There's something blocking their oxygen. And now even, and something that I've noticed, and I think a lot of people don't talk about, especially the biohackers who take all the supplements and the vitamins, NAC. In some people, if you're taking it every single day, I think it shows up to an 8% increase in hematocrit and hemoglobin. So. And I said that happened to me, and I would have rather been on a massive dose of testosterone to have that effect rather than taking it from a supplement called NAC. So I guess barring that, with the hematocrit and hemoglobin, what final thoughts do you have on it?
As I said before, the human is an interconnected series of systems, and the red blood cells are basically the fuel that is flowing through your body at all times. So everything is going to influence this to some degree. I think that it's very important that people look at if there's something going on in their health that's wrong, that's not something like genetic hemochromatosis or something like this, that they're going, what am I doing that I shouldn't be doing? And what am I not doing that I should be doing? Because just because you don't understand how that's connected to this doesn't mean it's not. So I think the best thing that people can do is go, if there's a concern with their health, not to reach for immediately reaching for phlebotomy, medication, whatever, being like, what could be off? What could I not be doing right? And I think that sometimes it's a blaringly obvious thing that maybe they wanted just to get away with and they're not. So I think that that's an important thing to look at. And the other thing with the I guess, and this would also tie into the blood pressure thing as well, is that you need to do cardio.
Yes, I was going to ask you that.
And my friend Jay Campbell is the biggest cardio proponent in the world. So I'll give him credit here because it's absolutely credit where credit's due. Is that you have to do cardio is not just a tool for calories out. You can do cardio from doing supersets and giant sets or whatever, but you have to do some form of cardiovascular training to be able to actually support having high testosterone levels. And it's I think, and again, this is actually, I'm borrowing this from Jay, is that when you go on TRT, you are now having a higher requirement for doing more cardiovascular training. It's kind of like if you buy a Lamborghini, you need to learn how to drive better than if you have a Suzuki Swift, because you're going to spin around the corner and going to spin out and lose control. So I think that when it comes to the daily health habits that people are looking at, if you're on TRT and you've got a total testosterone, like you mentioned before, 30, and your blood pressure is 150/90, is the solution to drop the dose, or is it to get a treadmill? And if someone's going, well, I'm not doing any cardio, I get out of breath when I go up the stairs, maybe the solution is to be able to tolerate the healthy dose that we want to give them, rather than to back the dose off because they're not doing the things they know they should have been doing in the first place.
I think when it comes to testosterone, you want to get the optimal benefits of testosterone, and testosterone will continue to become more optimal for you until you take too much. There's not a lot that's changed in injectable dosing for testosterone in the last few years. It puts most people in a ballpark, but it's not right. So the thing that blew me away at the Olympia, like I've been in an echo chamber for a long time of people who are really